Now let's talk about some of the intraoperative challenges when you're going to address these patients. And I think one of the things is you prepare for the worst and get hope for the best. So prepare, because you don't want to encounter these problems and not have a solution. So when I think about these cases, there's a multitude of problems, but kind of four main problems that I'm thinking about as I progress through them. Number one, you know that the adhesive lysis is going to be complex. Obviously, lots of previous abdominal surgeries can make things very challenging, mesh in place that you have to work around. When your hernia becomes so large, my practice is all transversus abdominis release. So when your hernia becomes so large, oftentimes I cannot get that posterior sheath together. So what am I going to do in order to get that close so I can have something that's covering the viscera so I can put my mesh on top? How am I going to close the hole? How am I going to get everything in? And then oftentimes in these patients, they can have significant soft tissue issues. So how am I going to address those? So let's talk about managing posterior sheath deficiency. So there are a couple of ways to do this, and I think start from the beginning. Plan to have not enough what you need. One thing that you can do is you can actually utilize the hernia sac and pull that off the abdominal wall before you start your retromuscular dissection. This is great, it's natural, can be utilized. I often use vicryl mesh in this situation. This is a lady that we've done the transversus abdominis release on, and you can see we are nowhere close to getting anything covering that viscera. And so I like to put a big piece of vicryl mesh in, sometimes two, in order to close that over top of my viscera. This actually also provides some domain as you are getting things closed. Other surgeons commonly use other absorbable mesh options. A big one that's being used now is phasics, which I think is great, but also maybe a little bit, lasts a little bit longer and can be quite expensive. So, how are you going to close the defect, and what mesh are you going to use? And I think one of the things to consider is this step was actually very recently published in Surgical Endoscopy 2023, that you're trying to balance the risk of a mesh infection or a mesh-related complication with a mesh that's strong enough to serve the role of these lots of domain hernias. And I think there's always the question of, can I close this hole? And what the group from Cleveland Clinic found was that when you did not close the fascia, your midweight polypropylene mesh had a 30% chance of breaking, especially for defects that were greater than 20 centimeters. And so in reality, you are going to have to figure out a way to put a mesh in that's strong enough to prevent that from happening. And so my practice is one of two options. Number one, you saw us sewing that heavyweight piece of mesh together. There's 4 pieces sewn together because they don't make a heavyweight big enough quite yet. Or oftentimes people will inlay 2 pieces of a midweight polypropylene mesh. I think one of the challenges to these repairs is you don't know you can't close the hole until you cannot close the hole. So I would say go ahead and put in a heavier piece of mesh to begin with. In general, the risk of wound morbidity isn't significantly higher when we use heavyweights. The other thing is what do you do, how do you close the defect? And so one of these things that I have learned is I interrupt my fascial closure in entirety. I have ran a midline incision as long as I can remember. And the key is to put all of your sutures in at once and kind of pull up and pull across. And this serves sort of like this new technology that's being utilized in Europe. It's called fascia tens. Basically, it's the poor man's fascia tens. I make the residents pull on sutures just to kind of slowly distribute that energy over time. I think another thing that helps a lot, which we kind of trended away from, is putting transfascial sutures in. So by putting those transfascial sutures along the outside of that abdomen, it kind of keeps your muscles a little bit more medialized. But there are also some times where you cannot get the hole closed. And I honestly think that is a reasonable thing. So how do you prevent these from getting in there? Your rectus muscles need a job. This is a patient that had a 40-centimeter hernia. You can see where her rectus muscles are by the asterisk. We could not get her closed. A little bit was because she's a very comorbid patient. And so I have now put in a piece of heavyweight mesh and sewn the muscles to the mesh, which I think is key. Because oftentimes you see these really large hernias, someone's like, oh my gosh, I cannot get this closed, and the muscles just retract. So you need to give the muscles a job, and you do that by medializing them and just sewing them right to the mesh. But I think it's also important to note that, is it worth it? As I said at the beginning of this talk, there's a significant amount of physiologic changes associated with these defect closures. And so the question is do people still benefit if you can't get a fascia closed? And this group looked at the outcomes when you just bridge the repair for massive ventral hernias. I think, remember, we're looking and caring for people who have a significant amount of viscera on the outside, often can't walk because of how heavy it is, and just restoring some amount of stability, even if it is just with mesh, significantly improves their quality of life. And this is what they showed, that at their last follow-up, when you look at the baseline, they had a significant improvement in their patient-reported outcomes based on the Hercules summary score. And I think the end of the day is hernia surgery is quality of life surgery. And if you cannot live because I close you so tight, you are not going to benefit from my repair. So I think there is some happy medium of I'm going to give you some amount of domain, but not cause some amount of complication because I've chosen to close your fascia tight. The other thing that I think is very important to understand up front is, are you going to have enough soft tissue to close over top of your defect? And this is something that you need to get plastic surgery on board because oftentimes you'll need a flap to do so. I often get our plastic surgeons to use ALT flaps because it is skin and soft tissue, which covers things. But also you can do innervated latissimus flaps. So this is what it looks like. This lady had a